Hello, my name is Spencer Hay, and I'm the co-founder and chief science officer at Prism Bio, and this is Discussing Data Science. My guest today is Dr. Joshua Lee. So Josh is a professor at NYU in population health and medicine, and he's an NIH-funded researcher conducting clinical trials on opiate and alcohol addiction. He's also the principal author for the Opioid Use Disorder Treatment Map, which is the most comprehensive resource for information about the evidence behind treatments for opioid use disorder in the world. This is hosted on Prism's platform right now. I will put a link. You can go check it out. So Josh, thank you so much for joining me today.
Spencer, great to be here.
So why don't we dive right into the opioid map? And I'd love to start with a little bit of the history. So, Prism got involved at the end of the project, but it'd be great if you could talk about sort of how the project came to be. Like, why did you decide to undertake this, kind of massive effort of mapping the evidence behind treatments for opioid use disorder?
Yeah, it really was an opportunity that kind of fell in our lap. We were interested, but I was not, I'm not a library science or kind of bibliography science. What we've done here is visualize individual studies, not actual data. So it's really like kind of rooting through the library and coming up with a way to show people how many papers came out about methadone that were randomized trial each year in the last 10 years. So that was of interest to me, though, because I'm always in that literature. We publish our papers when we do studies, when we have data to analyze and talk about. And so I'm a part of that. That's my industry. That's my team. It's what we're doing at my institution, and of course throughout the world. When you're working on these things from a clinical trial and science perspective. So it sounded like fun and what I kind of like to do anyway. And I'm always my background before medical school was included a major in art history.
Oh, wow.
And that related to what I did in med school because I just got used to running up and down the library looking for obscure articles. Like, wait a minute, you said this in 1970, but you're referring to something in 1965, and that guy didn't actually say that. So kind of that bibliography and citation detective work I've always just personally like kind of geeked out on and enjoyed. So that also was of interest to me, at least, if not the rest of my team.
Yeah.
For this kind of project. But really, it came from a funder. Spencer, you and I can talk about this as we go along in the arc of the project, but we were both working with the Laura and John Arnold Foundation on different stuff.
Yeah.
And one of the project officers, Julie, was at one point basically kind of shopped it to us, saying, what if we gave you a little bit more funding? Here's a new project. Like, as a grant giver working in the opiate kind of treatment and prevention space, we are just internally kind of struggling with what is needed, what next, what's the holes to fill. Like, if we already know, buses are okay, what about super electric buses? Like, what's the next thing to do in terms of policy, in terms of like applied science? How do we treat people day to day in our communities? And that's how the idea started. And we said, we like that idea. And, if I staffed it kind of with a kind of a postdoc or a research coordinator type person for a year, it was a limited budget as these things go. And in terms of the size of these grants, it was a small one. But it gave us enough to get started. And then since then, we don't work directly with Arnold on the project anymore, but the project lives on because we've tried to get it to a point where we can maintain it with some volunteer work, with some kind of paid, but, kind of internally funded. And then, of course, we're interested in more funding down the road if that became possible. But it's become a thing that we can kind of maintain within our academic kind of our in-house resources. And we hope to keep it going as a kind of living map that just doesn't peter out, at the time we published it, and was never updated. So the goal overall, though, was to really kind of take this new methodology of evidence maps and apply it to opiate use disorder treatment science, implementation, and eventually policy. So what we do that's practical and effective to prevent overdose, to save lives, to reduce heroin and fentanyl and other opiate use, to reduce HIV infection within people using drugs or opiates in particular, and that's what we're doing day to day anyway in Bellevue Hospital, where I work and where I treat patients. And so this map was trying to show the world's kind of cluster or universe or solar system of studies, but also focus on opiate use disorder treatment. So that was the other thing. We were trying to make it practical, something that NIDA or a state government official or somebody new to the research or someone much deeper on one end of the neighborhood versus the other could use to kind of see what was kind of functionally applicable to real people in the present day in terms of their condition and what kind of treatment they might consider. So it's not about always, although some of the studies touch on this, but it's not about epidemiology. It's not about neuroscience in the sense of like rat brain studies. It's all about the treatment of opiate use disorder in human beings. And so that ignores other huge parts of what's important, what the NIH and other people fund. But just to make that point too, it was trying to do a kind of narrow and kind of practical, essentially like a primary care doctor's view of opiate use disorder and what we should do about it. And that's my background too. I'm a primary care doctor. So we wanted to make it kind of accessible, get into what PRISM can do with data visualization, which my team can't, and we're totally new to that. So that was like also the lucky part was like bringing this to your team and then just like collaborating.
Yeah.
We would not have arrived at what the thing looks like, without you and PRISM's help, creativity, knowledge base, which we were totally just buying, right? Like we had none of those in our skill set. It's not something I'm trained to do or have ever done before. So we really needed, that kind of help to make it a real kind of usable, publicly accessible product.
What is sort of, when you look at the map, right, or sort of when you kind of think about it as like, obviously, as you hit on, right, the idea is to have this be an evolving thing, but sort of given the state that it's at today, I mean, kind of, do you have a top line sort of insight or takeaway? Like if there's kind of, one or two things that you think of, like, somebody who's going and looking at this thing, here's what I want them to see, because this is like really critical to like what they need to know.
Yeah, it's not rocket science, as they say, but it does reflect what we do day to day and how we train our doctors and nurses and counselors to work with opiate use disorder, which is that medications are extremely important to our treatment paradigms. It's a lot. We spend less time and money on non-pharmacologic or counseling or behavioral interventions for opiate use disorder, but that's not to say they don't work or don't have a place. But you can quickly see that in the map. It's a little, it's a distinction that is important to make, and yet you'd have to kind of go to the map and use it to understand this. The map is not pointing you to the right answer. The map is simply cataloging study after study after study. That has an implication as to treatment effect, effectiveness, hierarchy of treatments, which is the best, what should I do first? Those kind of like clinical algorithms. And if you for a moment say those are kind of related, which they are, the biggest parts of the map where we've done the most studies, where we have the highest quality studies, where you have the most patients that have been studied for decades now, is clustered around medications.
Yeah.
So it's not to say other stuff doesn't work, but it's to say that medications, the arrow's kind of pointing at methadone, buprenorphine, and naltrexone, which, not surprisingly, are the three kind of classes of FDA approved medications for OUD in the United States. Those are where, a lot of the energy has been put. It doesn't mean that's all we should do in the future. So then the other fun part about maps is the gaps.
Yeah.
Like I'm looking at a map behind you, like there's the continents and then there's the oceans,
Yep.
and in terms of like what we know the most about, it's the continents. The oceans are more kind of unknown. That's not to say, so that's like if you wanted to really look for new breakthrough areas, we might start, thinking more about deep ocean exploration. That's a weird kind of parable there, but that is a fun to do with the map. So, and the opiate use disorder, we just know from our current practice and from our patients and from the epidemiology, it's changing, and it's changing all the time. So does anything work in the age of fentanyl? Like you
Right.
can't find any paper in that map that really isolates reduction in fentanyl use as opposed to other opiates, heroin use, general kind of use of opiates. Like, no, let's talk about people smoking fentanyl in Portland, Oregon, just to quote like a recent New York Times photo essay. That's like really new. Like the cartels are pressing fentanyl into pills, and you don't even buy a little bag of white or gray powder anymore, which is how in New York City, at least, we get our fentanyl. And there's still mixed in there a little bit of heroin. But in Oregon, it appears as though people are buying fake pills, or they're not fake, they know they're fentanyl, but that's how it's packaged. And then there's a lot of smoking and a lot less injection. We need to keep studying that, and the map needs to start doing that. But if you could quickly kind of use our filters and kind of select for studies and find that there's not much about like what exactly is going on in Portland, Oregon right now. So that is maybe we should start work in that area. Maybe funders should start, moving a pile of chips in that direction, because it's an area where we don't know much about, like treating fentanyl use disorder as opposed to other forms of opiate use disorder. So that's one example. Special populations, you can just see that there's a lot less that is focused on, for instance, homeless individuals versus general population individuals. That's like a really important and unfortunately kind of growing segment of the population, and it reflects, horrible housing inflation and kind of the lack of affordable housing throughout the country. That has nothing to do with opiate use disorder, except that it does, because a lot of folks are wound up in an unfortunate cluster of problems, and addiction and opiate use disorder relate to or stem from or can cause, in all the different directions, homelessness. So maybe we need more studies looking at homeless veterans who have opiate use disorder and are at super high risk for overdose. We know that to be true from kind of overdose statistics. And so but there's not much in the map, that you can see that if you wanted to make a career as a young gun, that might be something to think about. So that's the fun part too. It's really just a record of what we've studied, but it only through kind of omission, and it doesn't directly tell us the answer, like what to study next, but you can get a sense of what might be important. And, oh, look, we don't have much on that. And so that was another fun part of the project.
Yeah. I mean, is this fair to say? I mean, it's one of the things that I think is so powerful about it, and powerful about like an evidence mapping approach in general, is the way that it can like sharpen your thinking around kind of like what you know, but also like what you don't know, right? Because it's like, it's not that you could never sort of, reach those conclusions as you describe, right? Because you could do a kind of, systematic literature review and like be looking at lists of papers and be like, oh, there's something missing. But somehow I think like bringing the structure, right, and kind of the structure that's required by the visualization, right, it sort of helps you see like, oh, okay, no, I can really see, like you were saying, it's like I see where the oceans are now, right?
Yeah,
it's like
yeah,
there's
totally.
a gap, and now we can prioritize in light of that knowledge, right?
Correct. I agree, and it was fun because I've not been a great systematic reviewer or meta-analysis author or researcher myself. That's great respect to people that do more of that and spend more time on those. But generally, a Cochrane review, it's isolated to a pretty narrow question. does aspirin prevent heart attacks in people that have already had a heart attack and are leaving the hospital? That's not to say we should all take aspirin. That's a different question. What about aspirin in me? I'm 50. I don't have cardiovascular disease, or if I do, I don't know it yet, that kind of thing. Like, what about aspirin for me, who has not had a heart attack yet? So, well, that's another Cochrane review. But in the universe of opiate use disorder, I'm going out on a limb here, but there's 20, 30 kind of related Cochrane reviews, maybe even not that many. But there's not that many questions you can quickly look up to find the absolute guaranteed, kind of gold standard answer for what to do in this situation, or what works best for this particular patient.
Yeah.
Another way we often frame it in med school. The map kind of does that in really as many filters and combinations of filters. And by filter, I mean a way to kind of code or classify a paper. What year was it done? Who funded it? How many people were in it? What was the study design? What was the intervention? What were the outcomes? What part of the world did it take place in? Were there multiple outcomes? Yeah. So those are all different ways of kind of that we're trying to kind of cut up and slice and dice these papers so that you could quickly sort by, I want to look at methadone studies in the 1970s from South America. Probably there were not any, to make a point also about regional disparities. But that's what the map lets you kind of quickly do. That's the power of it. That means that it didn't tell you the answer, like, and what did they find, and how great was methadone, or what harms was associated with. It doesn't like spell it out for you. You'd have to go look through those 6 papers, say, if that's what resulted from that node of the map. But it gave you a head start on a systematic review of a very narrow intersection of these filters, or ways to classify the literature. And you can do that. I mean, we can do the math. There's tens of thousands or maybe even 1 million different iterations or in combinations in that one map, simply because we chose a lot of filters, and you can then mix and match intervention, outcome, and type of filter over and over. So it lets you quickly do your own systematic review in terms of kind of like we said it in the paper we published on this. One of the great features of PubMed or COVID, the National Library of Medicine interface that most of us use, and is kind of the backbone of med literature searching, is related articles. So Spencer wrote a paper about aspirin prevented heart attacks, related article, and you get a general sense of what else has been published, but it's always like spotty and a little random. And I think on the back end, it's working through mesh terms to do that. But it's similar to what we've tried to do here in the map, which is what else pops out kind of under that term or under this combination of terms. But it's quicker, it's more efficient if you already have all the OUD literature sitting there, and you're not asking PubMed over and over to do related article searches for different questions. In a sense, like, that's the innovation and power of the map that you can't get from existing search engines right now.
So you've touched on this already, but maybe just to circle back to it, what do you see as next steps? I mean, you kind of mentioned, there are gaps that were, uncovered, right? You sort of mentioned thinking about sort of folding in kind of policy, like research on like, what policies have been tested. But are there sort of other things that you see, like, here's kind of where you see it going?
Yeah. I mean, I think just like my own perspective on the opiate epidemic is like, I can go back to clinic and write more buprenorphine prescriptions, but it hasn't quite kept up with fentanyl. Fentanyl does seem to be isolated to North America. That makes it like a trade or economic, certainly drug interdiction, but like it's a political thing. Like they're
Wow.
using plenty of opiates throughout the world, at least in terms of, where people use heroin. That's ignoring like prescribing of opiates within medical settings, which is also different still in the United States versus other countries. But like, why do we have all this fentanyl? And how do we go back to abusable but safer forms of illicit opioids, which they have in Europe or Asia? And that's like, why don't they have fentanyl if it's so great for the cartel and stuff like that? That is to me the biggest
Mm.
problem that we need to solve and that no one has, and is not really necessarily a treatment provider problem, but it's screwing everything up in treatment. Like not as many people seem to be doing as well in all our great treatments as they have been in the past in the age of fentanyl. So
Wow.
the map, we were talking that example like from Portland versus New York, and the drug supply is different, and fentanyl packaged in different ways and used through different routes. We want to keep up with that, but that is like, I don't know the answer for what to do about fentanyl, but that like kind of does have this policy implication where like it's not just about the treatment of the individual patient, it's more about these macro factors that are going to have to be sorted out or improved to get kind of macro change, and to have that US opiate curve, flatten and come back down, and
Yeah.
get rid of a lot of the area under the curve that's there because of fentanyl. So like big picture, I don't know if the map is the answer or what part we'll play, but I see that as like the most pressing problem in my field. And it's not something I, as an individual doctor or prescriber or scientist, am in a great position to like figure out. But that's what I want us all to figure out quickly. But the policy tab of the map is not up there now, and it will be, we hope, soon. No exact timetable being promoted here, but that would be a really kind of fun, new, different way of looking at, what we do about opiate use disorder, that gets away from an individual getting treatment at a certain place and in certain modalities, which is kind of how the map works now, but more like, what can we do for communities, entire zip codes, counties,
Yeah.
states, mostly US focused, but of course you could apply, in policy science, like stuff that happens in one part of the country to the other, and in one country to another.
Why don't we transition now to the sort of last bits of the discussion here with our 3 questions that we ask everybody. So first question, what do you see as the biggest data gaps in your field?
Probably I'll tell you this is both in the map, and I'm just telling you because I do this for a living. We have great treatments. Treatment A is rocking. In this trial, treatment A was way better than anything else. If nobody can stay on treatment A, in this case, like methadone, buprenorphine, or naltrexone, the drugs that we prescribe a lot of, then it's not very effective, actually. And we're finding that retention on these same core drugs that if you do take, definitely keep you healthier,
Yeah.
is not great, and maybe worse, maybe getting worse again, like back to what fentanyl is doing to people's kind of a disease trajectory and natural history. It's not quite what we've used to or what we've seen before or what we knew about. And so what does it take? We already have the best drug, but like, how do I improve your chances of staying on it long term?
Yeah.
And that's not another drug, or the drug itself has done all it can. So what else psychosocially, policy wise, within the clinic, outside of the clinic, in your neighborhood, in your households, in your account balances, what used to be the clear answer was get people health insurance. And thank God in the United States, we have pretty high rates of insurance, and other countries probably have even better rates. But we've essentially, through 2008 and Obamacare, made vast strides in getting more people with OUD insured. Not enough are, and it varies state by state, so we can improve there. But like that used to be the answer. Like how do you boost treatment? Make it more affordable, accessible, and don't make it a pocketbook issue. And even if you do that, though, in a state like New York, where Medicaid rates are like 97%, and most of the patients I'm treating have no problem getting health insurance and getting these medications paid for, we can't keep people on them long enough. And we're still losing people to dropout, eventual overdose, reincarceration, in and out of the hospital, never really kind of stabilizing. And 5 years later, they've died of an infection. There's so much room for improvement in terms of optimizing, what we think should be guaranteed outcomes, and they're not.
Question 2, Josh, what excites you most about the future of research?
Wow. Great people. I think it attracts, again, linking to, if you fund it, they will come. Like the budgets in addiction science have been pretty good. I'm not complaining. And it has attracted a new generation. We see it in our addiction medicine fellowship, which is not all researchers, but people that want to do this for a living in terms of treatment, and in research trainees, junior faculty. There's a lot of like smart people that are younger than me that like the kind of stuff that we've been doing and can hopefully take over and run with it, the next 50 years. And that, of course, you just want to see that in the field if you care about it. And, it's so gratifying to kind of like turn over the wheel to somebody who has, at this point in your life, more energy, more ambition, is probably smarter than you were, all that kind of stuff. So that's a lot of fun if you can attract like the new generation of talent. But of course there's not enough, and just all hands on deck. We need more help. We need more kind of docs to provide the kind of treatments that we're promoting and researching, and then more people to, run with it as experts. But I do think, as opposed to like when I went to med school, if you talk to med students now, they're more focused on these social problems as health problems. Social determinants of health is, the kind of catchphrase that is getting more and more attention in curriculum and in kind of training, and then just in people's consciousness. The opiate epidemic has, done a number on younger generations that probably didn't quite affect me and Gen X. Of course, people up and down the age ladder have had problems with opiates, but if you were in high school in the 90s and 2000s, like that was a lot tougher opiate wise, in terms of your neighborhood, your community, people you knew. And a lot of those people now, of course, are medical professionals, and they like really have a passion for this that was new to me when I got into the work. And I probably never quite have, like, I don't have as deep or personal connection to the opiate epidemic, although I've been treating it, for years now, because it really wasn't a thing for me in the late 80s in high school, and it was not a thing for my immediate family. Not to say that we're free of problems or addiction, issues, but the opiate epidemic specifically was not something that touched me, and it really is different though with people born later. And then as trainees or new attendings or whatever in our health system, like people just are ready to rock on this issue in a way that my generation was kind of caught us off guard. So that's fun to see.
All right. Question 3. If you could wave a magic wand, what would you change about research, about the industry, about medicine? What leaps to your mind?
Oh man. On a personal basis, I would just like magically have written and published all my papers that have stacked up, especially since COVID. I'm like so behind on writing. Yeah. That's always like my deficit as a professional. Waving wands, back to like the public health wise, Can we just not have fentanyl? Like,
Right. I was going to say, it's like
we
based
have,
on this conversation, it's just like, how about no opioid epidemic anymore?
yeah, no, I know,
But
I know.
it feels
But
weird to laugh
that's
about
like,
that.
that's not the hope. Like, people use drugs, alcohol, chemicals. Some are good, some are bad, some are more or less harmful.
Yeah.
Um, I'm not a teetotaler. I don't think it's a reasonable expectation that humans won't use mind altering stuff or mood altering or whatever to kind of tweak their daily life. And that's fine. And like, there's no reason to expect that would change, because we've been doing it a long time. But like, is the only way to use opiates today in my county fentanyl?
Yeah.
Like, like that just seems absurd. And we know that's the case. Like, if you want to get your fix, or you need to because you're sick, or you're just feeling like that's what you should do today, your most likely option is something that like easily could kill you.
Yeah.
Like, go use a bag right now. You're not quite sure what you're doing. You don't do it absolutely safely. You do it by yourself versus with people. That's why the overdose epidemic is what it is, and it's gotten so much worse kind of year to year. And that just seems like completely absurd from a kind of law enforcement, drug interdiction, safe supply versus unsafe supply. Like, I don't know what I'm proposing here. Like Percocet vending machines. A lot
Yeah.
of people died thanks to Percocet, so it's not all rosy when you think of the early days of the opiate epidemic either. But is there not some other way to manage like illegal drugs and opiates in particular, and fentanyl? Because if there isn't, there's just no end to this until you've killed every person that is curious about opiates.
Hmm.
And that would be a huge percent of the population. And just kind of, burned out the epidemic, which does happen in drug epidemics. Like, we're not all smoking crack cocaine these days. And that was,
Right.
that was like part of the Newsweek headline from 1992, just like, it'll never end and it'll decimate entire cities. And it certainly had its harms, but the next generation wasn't as interested in it, in part because they were watching all those harms accrue in their neighborhood and their parents, yada, yada. So maybe we just need more time and enough people to die, and then there's no more like new users. That's one way to look at drug epidemics, but like, good God, it's like, it's so out of hand in terms of how dangerous the drug supply is, that I don't know. I'd be interested in what the DEA, FBI, NIDA, SAMHSA, President Biden, like the governor of red states, blue states, like, do you have any new ideas besides just like trying to arrest Mexicans and offer people Narcan, which is great, of course, but talking about Narcan, but it's not going to necessarily prevent the next overdose.
Yeah.
So there you go, Spencer.
I mean, that is a very interesting magic wand answer, I have to say. But,
Yeah, we need a safer drug supply. That's what I want. I
yeah.
don't want people to stop using drugs. I want you to do what you need to do. Live free,
Yeah.
but not the like live free or die part. Like
Yeah.
it's just too easy for people to make mistakes with fentanyl in the water. That we need clean water, clean air, and
Yeah.
cleaner opiates. And that again is not to say you can't have a devastating health problem that kills you with other opiates, but it's way out of proportion with fentanyl.
Well, Josh, I mean, it feels rough to end on that note, but, super interesting, super important, right? So I appreciate your
Yeah. Well, yeah. I mean, look, our treatments work and they're good. So if
yeah.
you do have a fentanyl problem, we can help you, and that's
Yeah.
great. And that's been the pillar of my career, is like, oh, I can actually do something about alcohol, smoking,
Yeah.
opiates. Like, most of what is killing people addiction wise in a country like ours.
Well, thank you again, Josh, for making the time to talk. Always great.
Thanks for having me.
For our audience, thanks for tuning in. Hit like and subscribe to never miss another episode, and we'll see you next time.